This is Anu Hasangdi from the Hepatitis B Foundation, where I'm the program manager of the Foundation's liver cancer program called Liver Cancer Connect. Today's webinar, Support Services for Families Facing Liver Cancer, is presented by Karla Pillote and Andrea Wilson. Karla Pillote is a nurse practitioner at Johns Hopkins Gastroenterology and Hepatology at Sibley Memorial Hospital in Washington, D.C., where she works with patients with liver diseases, including liver cancer. Andrea Wilson is a writer, editor, consultant, and advocate. She founded the organization BlueFaery, the Adrienne Wilson Liver Cancer Association, in honor of her sister Adrienne, who died of liver cancer at the age of 15. Today, the panelists will talk about what it means to enter the world of liver cancer and will describe some of the services and resources that are available to patients and families as they face liver cancer. This will be an informal webinar, and we encourage you to send in questions during the entire presentation using the chat box feature. This is located in the control panel on the side of your screen. We'll try to address as many of your questions as possible, and we'll also be posting the responses to all of the questions later on our website, livercancerconnect.org and hepb.org. With that, I'd like to turn it over to you, Andrea, and ask you to tell us briefly how you entered the world of liver cancer.
Okay, thank you so much, Anu and the Hepatitis B Foundation for having me here today. On May 16th, 2001, I heard the worst 8 words I've ever heard in my life from an ER doctor. He said she has tumors in her liver and lungs. And it started when I came home that afternoon. I found my sister, whom I raised from the time she was 8, curled up in a fetal position in our living room floor and actually asking to go see her pediatrician. And he took one look at her rather bloated stomach and sent us to the ER, where they did a CAT scan. And it was after that CAT scan I heard those 8 awful words. We were also immediately transported that night to Children's Hospital, Los Angeles, via ambulance, because our local hospital, as he put it, was not equipped to handle that situation. 2 days later, Adrienne had a biopsy and was diagnosed with stage 4 primary liver cancer, also known as hepatocellular carcinoma, or HCC. And stage 4 means the tumors had metastasized to her lungs. In 2001, there were very few options for anyone with HCC, and really no options by the time you had advanced to stage 4. More blood tests revealed that Adrienne had chronic hepatitis B and C, most likely contracted at childbirth. She underwent many rounds of chemotherapy throughout the summer, and she died on day 147 on October 9th, 2001. She did pass away at home surrounded by friends and family. So it was quite the introduction, and our whole lives were turned upside down in 6 hours, really.
Thank you, Andrea, for sharing. That was clearly a very traumatic time in your life. Karla, I'd like to turn to you now. Entering the world of liver cancer, the situation that Andrea described is somewhat unusual in that Adrienne was a young teenager. Can you describe some of the other patient scenarios?
Absolutely. I think, and fortunately, I think the diagnosis and treatment that we have available for liver cancer has changed a lot since 2001. It's still a very challenging cancer to detect and treat, but I think we've come a long way in recognizing what patients are at risk for developing liver cancer and screening them for liver cancer, getting them into treatment, and developing more treatment options for them. Many different things can lead to liver cancer. Basically, anything that causes disease in the liver could lead to liver cancer. A viral infection, such as Adrienne had of hepatitis B or C, or other autoimmune or genetic liver diseases, all of those diseases of the liver, no matter what their cause inflammation and scarring of the liver. That scarring leads to cirrhosis, and that scarring is what can lead to the development of cancer. So patients can have a number of different sorts of liver disease that put them at a greater risk to develop cancer. And hopefully those patients are engaged in care so that we are finding these cancers earlier in their disease course where they have more options. When a patient is found to have a lesion on imaging, then we refer on to figure out there's a lot of different lesions that can happen in the liver. And so we have to sort those out to say, is that a hepatocellular carcinoma or HCC, or is it some other kind of benign or not dangerous mass in the liver? But once we've done that and determined that it's an HCC, there are a number of things that need to happen. Next slide. I think the first thing from a patient perspective is if you've been told that you have a lesion in your liver or mass in your liver that might be a cancer, the most important thing is trying to understand that diagnosis and learn all you can about it. There's a lot of different terminology that we use with liver cancers, and it can be very confusing. And liver cancer, I think, is treated differently than some other cancers and approached from a treatment standpoint in a different way than other cancers. And so as you go through this process, it may feel very different to you about, well, why is this happening? This is different than my friend who had breast cancer. Why is it so different? The first thing they'll do if they see a lesion in the liver that they think is a cancer is determine, is this a primary liver cancer? Did it start in the liver, or did it come from somewhere else? And today we're just talking about cancers that start in the liver. The medical folks are going to look at what is the stage of the cancer, and that involves what size is the tumor, how many tumors are there, how are the tumors behaving within the liver, is there evidence that the tumors are getting into the blood vessels of the liver, what is the overall condition of the liver in terms of the underlying disease that's there. Those are all things that go into saying what stage are we at. And that stage is important because the treatment options that we have are determined based on what stage of cancer there is. Your options are going to revolve around surgery to take the tumor out, or other measures to try to limit the growth of the tumor or get rid of it altogether. And we'll talk about those a little further down in the next slide. You may need more testing. If your diagnosis has been made based on an ultrasound or a CAT scan, your doctor may want to get an MRI or additional imaging to further look at the cancer and get a little bit more detail about the mass that is there. You may be in a center, you may be referred on to a center that has more of an academic center or a larger medical center where there's more specialized care, and that's also something that we're going to talk about today. You may want to get a second opinion. Once you understand the cancer and you've heard the treatment recommendations, a second opinion is a great idea to really help you further understand it and decide which of the options is best for you. Next slide.
Yeah, and before we do that, Andrea, how was it for you and Adrienne what did you go about getting how did you go about getting in the information that you needed to understand what the diagnosis was and what would be involved?
Well, I asked for information right away, and the surgeon who did Adrienne's biopsy said no such thing exists. And I thought, well, this doesn't make any sense because we were given one-page documents about her chemo, and he said there's no information for patients. So he actually made copies out of his medical textbooks all about hepatocellular carcinoma. And then I had to buy a medical dictionary so I could translate all of it into layman's terms. So in 2001, there just wasn't a lot of information available to give to patients, which is why one of the first things my organization did was to create a patient education brochure written in layman's terms so patients do have that knowledge and know what questions to ask.
Yeah, that's very important. So Karla, can you give us a brief overview of what those treatment options are for liver cancer? I know it's a little bit different from other cancers, and can you explain how?
Yeah, it is different. I think people who liver cancer is approached very differently. A lot of times in other cancers, when you see a mass, for example, a breast mass, the next step is to do a biopsy of that mass to say, is this cancer? What type of cancer is that? And a lot of times with liver cancer, in fact, most times we don't do a biopsy. Because we use the specialized imaging that we have with MRIs to differentiate whether it's a cancer or not. Doing a biopsy to go in and take a sample of the tumor itself can cause seeding, meaning that putting the needle in and then drawing it back out from the tumor can actually pull cancer cells into the liver. And that's a concern in terms of basically helping the cancer to spread. So a lot of times we don't do a biopsy. So you're being told a diagnosis based on pictures only, and perhaps some lab tests that support that. The other thing that is very different as we talk about these treatment options is that a lot of other cancers are treated with surgery. Liver cancer is not always treated with surgery. A lot of cancers, patients get what's called systemic chemotherapy, or chemotherapy that is infused through the veins and goes all over the body, is targeted for that cancer that the patient has, but they're getting either radiation therapy or chemotherapy through an IV as part of their treatment. And those are things that we don't do in quite the same way with liver cancer. The treatment options are four main things. And again, this based on the stage of your cancer. If the lesions are small and there aren't too many of them in the liver, then one of the best options is to consider liver transplant, which means taking out the liver completely and replacing it with a healthy liver, either a liver from a deceased donor or part of a liver from a living donor. And that's a very complex process to be referred to a center, to be evaluated and listed for transplant. But we do that quite frequently with liver cancers. And while the patient is waiting for their transplant, we do proceed with some of these other treatment options in the meantime to make sure that the cancer hasn't spread. Surgery, or taking out a portion of the liver where the tumor is, can also be done if the tumor is small and if the patient is otherwise healthy enough to have surgery. When a patient has liver disease, their risk for having surgery and having complications after the surgery goes up significantly. So if a patient has cirrhosis because of hepatitis B and they develop a liver cancer, the lesion itself may be small enough that it could be taken out surgically, but the patient as a whole may be too sick to undergo that surgery. So sometimes surgery is an option, sometimes it's not. The localized therapies are, I think, what we use most frequently with patients, especially patients in our practice, a lot of whom have underlying liver disease and fairly advanced underlying liver disease, that surgery is not an option for them. And these are very specialized treatments that I think are complicated and a little hard to understand, but once you understand them, they're actually kind of neat. Because basically, it's these treatments, the radiofrequency ablation, the transarterial chemoembolization, and radiotherapies in general is basically going into the liver with very specialized probes going right to the tumor and either using radiofrequency ablation or sort of zapping the tumor, or using chemotherapy to eradicate the tumor on a very localized level. And what's good about that is that it targets that tumor and seeks to destroy that tumor without destroying all of the surrounding liver tissue. And it's a treatment that can be done multiple times to multiple lesions. And then there is targeted oral therapy. There is an approved drug called sorafenib, which is a treatment that, a drug, a pill that is taken that tries to prevent the tumor from spreading. And it can slow the progression of a tumor in the liver. And it's not a first-line therapy for liver cancer, but it is something that we have available.
Okay. Andrea, what were the options when Adrienne was given her diagnosis?
Well, there weren't really any options. Sorafenib had not been available yet. I don't even know if it had been invented yet. Things that, such as TACE, where you see under localized, was not an option because the tumors had spread to her lungs. So they just threw chemotherapy and immunotherapy at it.
Okay. All right. Go ahead, Karla.
I was just going to say that these treatment options are highly specialized, and so depending on where a patient is and where they're getting their care, these treatments aren't available at all healthcare centers or hospitals, and so patients may well be referred to a larger medical center for these sorts of treatments.
Okay. So Karla, at these larger centers, we know that they offer the concept called multidisciplinary care. So can you very briefly tell us what that is?
What that means is that there are a lot of different aspects to treating a patient with liver cancer. We have to treat the underlying liver disease, the patient as a whole, and treat the cancer. And so there are a lot of different types of providers that get involved in the care. And when we say multidisciplinary team, it's not just that you have a big list of doctors or healthcare providers, but it's a team that works together. And in our center, we have all of these people, all of these different sorts of providers involved in a patient's care at different times during their treatment. And there's a lot of communication, both formal and informal, that happens about a patient and their treatment as things go forward. A lot of times when a patient is first referred to us, and we have seen the patient, we've got imaging, we've got all the data that we need to say, what should we do here? It is this team that sits down as a group at a conference or a tumor board and discusses all of the aspects, all of the data around that patient's situation, and sort of everybody can put their 2 cents in and come to a consensus, taking into account all of the variables that we need to say, this is what we think is the best treatment option for this patient. So the good part for a patient is you've got a lot of brains working together to say, what's the best thing to do here? What other information do we need? Do we have everything that we need to offer the very best, the most aggressive treatment to this patient?
And I know that also the National Cancer Institute has designated cancer centers that provide these types of multidisciplinary approaches. So, Karla, you already mentioned that for the individual treatment plan, we have to see how well the liver is working and the stages of the cancer, as well as the overall health of the person being treated. A lot of the times where people are concerned about the effects of cancer, especially the side effects, what sorts of services or resources are at your center to help patients and families cope with that?
I think that, that whole team of people, I think patients being well engaged in care, being seen frequently, I think all of us on the team then have an opportunity to help impact these things. But I think that, depending on the treatment and what treatment is being undertaken, there is a lot of fatigue. Patients are very tired, and they may be tired from their underlying liver disease and in addition from the treatment. So it can be a very difficult time. It also can be that a patient felt fine before those treatments started and now suddenly is dealing with symptoms that they weren't expecting. And that can be very difficult, and especially for a patient who's never otherwise been sick and has never had to deal with fatigue or nausea or vomiting. Those aren't things that you necessarily know how to deal with. And so I think the nursing care and medical care and using all of those resources, the pharmacist in terms of helping us with the pharmacologic management of symptoms, all of those things happen. Pain can be a part of the disease, and that is something that is important to manage and manage well.
Yeah. And Andrea, how about the emotional turmoil? How did you and Adrienne cope with that?
I'll address that. I just want to back up for a second. Adrienne was seen at an NCI designated cancer center when we transferred her care from Children's Hospital to UCLA, but it really, as Karla mentioned earlier, is about staging. And since she was already in stage 4 with metastases in her lungs, there really were no options but palliative, which I know we'll address later. As far as managing the effects, I think as a caregiver, you are very hyper vigilant and alert and sensitive to any change in the patient's behavior, mood, or appetite. And I remember reading as a parent that when your child gets cancer, that the child should resume their regular chores, that there should be as much normality as possible. And it made me laugh because that just didn't happen in our house. You know, my sister was either didn't have enough energy, as Karla said earlier, and typically it was from the treatment. It wasn't from the cancer itself. Or her doctor actually said she couldn't do certain chores because we wanted to keep the environment as clean and sterile, even in our own home, as possible. So it is, it's very difficult. It really is for everyone.
Mm-hmm. I think too with this is not this is a cancer that is treated and followed over a long period of time. Adrienne's situation was different, but now that we identify patients earlier and have treatments to offer, we can keep patients healthy for a longer period of time, which is fantastic. But that also means that the patient carries that diagnosis, that uncertainty with them through daily life a lot more. And I think there's a lot of uncertainty of what will my tumor do? How will my tumor behave? And there aren't really solid answers to that other than to sort of wait and see. And that, I think, can be very difficult for patients. You want an absolute answer. You get a treatment, and we know that even after a resection or a successful TACE treatment, that there is about a 70% chance of recurrence within the 5-year mark, that the cancer will come back. And so that uncertainty will stay for patients, and we have to help deal with that.
I agree, Karla. I remember Adrienne usually had a CAT scan a few weeks after her chemotherapy treatment, and I remember thinking every time, oh, I'm waiting for this magical word, change. There's been a change. Because we kept hearing, there's no change, there's no change. And I didn't think through that thought, because the day that we heard there was a change, which was about 3 to 4 months in, it was a change for the worse. And I didn't see that coming. I really didn't.
Yep, it's very, very difficult for patients. I have patients that say, I live my life now in 3-month increments. 6-month increments, and that's hard.
So, Karla, life during treatment then, what exactly is involved in terms of what they have to do with their follow-up visit and talking about their wellness plan?
Mm-hmm. Well, I think one of the most important things is for patients to be very actively engaged in care. And, you know, the treatment that you have is very important, but the follow-up to that treatment that you have is honestly more important, because sometimes patients, we have a hard time sort of tracking patients down and think, well, I got my treatment, I'm okay, right? We need to, getting the imaging done, making sure that the liver function as a whole is as good as it can be, that medical management of whatever the underlying disease is, very, very important. The effects of treatment may last for a while, and so a patient's not going to feel quote-unquote normal for a long time, or perhaps not again. So it's really important for us to do that monitoring with the imaging, with lab work, with, you know, seeing a healthcare provider, getting a physical examination, talking about what symptoms the patient's having and dealing with those. And I think part of that is a patient sort of getting to know themselves and their own bodies, and really forging a relationship with the providers to say, hey, you know, this is happening. What does this mean? Maybe it doesn't mean anything, but I want to ask about it. The other point, if we go back to that slide for just a second. Oh, no, I'm sorry. Go ahead. You can go to the next slide. I'm sorry.
So this one?
Yes, yes. No, to the next. Okay, I'm sorry. Also with follow-up care, I think the two bottom points there in terms of maintaining health insurance, so that you have access to the care that you need and the specialized care that you need. And also, because this is over a long period of time that patients are treated and followed, you know, doctors come and go and change, and people on your team may change. And while we all have each other's records, it's important for the patient to have those records as well, and for a patient to really understand what treatment they've had, where they stand. So don't be shy as a patient to ask questions, ask for that information.
Andrea, I know that you're an avid note taker. Can you give us some tips on how you did this, and how did you keep all of that information together?
Yes, I am. Well, the first 2 weeks I did not take as many notes because I was so busy learning about the cancer, but after that we had a spiral notebook and we took notes every single day. And there were some healthcare providers who weren't fond of my notebook, but it turned out to be a good thing because they were making the transition from paper records to electronic records, and they had actually lost some information on some pain medication they had given Adrienne during her first week in the hospital, and they asked me if I had, you know, the information written in my notebook, and I did. But it's very important because it, you know, it can, well, especially while you're at home in between treatments, you might see patterns, and you can let your oncologist know, well, we noticed on these days this is how she was feeling. But I wrote down everything. I wrote down when I gave her medication, how she was feeling, any side effects she experienced, and then when she started getting too dehydrated, I started monitoring how much fluid intake she had every single day, which drove my sister nuts. And you know, it was good. It was a medical diary, and it was really important and really helpful for us, and I think later for her physicians, because if they had questions about something, I could just go back and look at the day and answer the question.
Yeah, that's definitely helpful. Karla, I wanted to ask about clinical trials, which are research studies. Can you explain, when you talk to patients about clinical trials, do they first have to go through all the existing treatment options, or can they ask about clinical trials even when they're newly diagnosed?
I think a patient can ask about clinical trials at any time. And I think that, we said earlier that treatment options have evolved and changed a lot in the last 10 years. And a lot of how that happens is through clinical trials. And, research studies are where people volunteer to take part in testing of a new treatment, a new drug, a new procedure. And for some patients, it may offer a treatment option that they otherwise wouldn't have access to, that may be actually very well tailored to their particular situation. So it's always a great thing to ask about. And, it may not be the right choice for some patients, but I think it can offer different options, which are important.
Yeah. And I know that the National Institutes of Health have clinicaltrials.gov, which is a comprehensive database of clinical trials, and you can search by state or by condition or by a drug name if you know that. The National Cancer Institute also has a clinical trials directory of trials that they support, as well as all clinical trials, and that's specific to cancers. So you can go search by specifically the liver cancer if you need more information on that. And on our website, livercancerconnect.org, we also have a clinical trials directory, which we'll be expanding on further coming soon. So now we want to talk a little bit more about the fear and the uncertainty. You both mentioned those are the concerns that a lot of patients and family members have. What are the treatment options? What happens if the cancer comes back, and what will happen to my family? I wanted to talk more about the communicating feelings. Andrea, I know you believe very strongly about being an advocate. So what does that mean exactly when you're a patient or a family member of a person facing liver cancer?
Do you mind if I comment on clinical trials for just a moment?
Sure. No,
okay, so Adrienne was offered 2 clinical trials, and both toward the end of her treatment. But I think it's really important to, if you are offered a clinical trial or you look at one that might interest you, to ask a lot of questions about it. And we turned down the first clinical trial for 2 reasons. One, it made no sense for her diagnosis, and 2, it was going to require that she go to the hospital every day. And Adrienne said absolutely not. So it's important to take into account what that patient wants in terms of their quality of life, and her goal was always to get out of the hospital as quickly as possible. So, and then at the very end, she was offered sort of a one-person clinical trial that we made happen because we had a connection at NIH, and unfortunately she wasn't able to start it, but she was approved for it. So clinical trials can be very valuable. Just ask questions. And that goes to being an advocate for yourself or, for your loved one. I mean, for example, as a patient, you have a right to see all of your medical records, including your lab results. In some cases, you might actually have to pay for films if you're maybe transferring your care, but your lab results are pieces of paper that you can have access to. And to me, the best way to make informed decisions about your health care is to be informed. Some doctors they don't tell patients everything, and that's why the advocate should be there to ask. And really do look at your options and think about your quality of life and how important that is for you.
Yeah. Karla, is there a specific point person who deals with these issues, usually at a hospital, for example, a social worker or a nurse?
It can vary. A lot of times, I think anyone on the team can provide those services, but in a lot of larger centers, there's either a case manager or a social worker who becomes involved with the patient and the family to deal with sort of the obviously related to the medical problems, but to deal with all of the other issues of maintaining insurance, financial issues, support issues, home care issues, planning for the future. And those, that can come from different types of people on the care team, depending on your center. It might be a nurse. But if you're not getting those services, ask for them. Who can I talk to about getting some extra support at home for my kids? Or, my children are having a hard time with this. How can I get them, hooked up with someone who they can talk to and deal with this? Things like that, seeking those resources.
Yeah. Yeah, it's very important, and also to stay informed. We'll talk a little bit now about the support services for patients. We're going to mention a few here. This is by no means a comprehensive list, but we wanted to just add a few resources here that are good starting points for you when you're looking for support services. Cancercare.org is an organization that provides counseling, support groups, education, and financial aid. And similarly, the American Cancer Society also provides information in Spanish and Asian and Pacific Islander languages. This is particularly important for in the areas of liver cancer because liver cancer disproportionately affects Asian and Pacific Islander communities. Maybe, and in terms of the support services for families as well, there's caringbridge.org, which provides information that where you can create communities, that caregivers can create communities of their own friends and family members, and it helps you to share information with your neighbors and family members so that you don't have to keep sending out separate emails. It's a site where you can share update information about each medical visit, share photos, and well-wishers can post greetings. Lots of Helping Hands is also a useful website. It's an online calendar, so if you're dealing with cancer, it can be very overwhelming, even just the logistics of taking care of family members, going to work, and working with insurance, and trips to the hospital for treatment. This online calendar allows caregivers and family and friend members to schedule meals, trips to the hospital, even trips like helping take the kids to school or picking them up from school. That's a huge benefit to caregivers, so they don't have to handle that on in an individual basis. Andrea, could you maybe give us some information about what online or other support services you used?
Sure. Our social worker was the main point of contact for that sort of thing, and there was a teen support group which we attended one time, and I realized that my sister didn't need that. I was the one as the caregiver who really needed supportive services, and I didn't know these were available. And I would add also Patient Advocate Foundation, and their web address is patientadvocate.org. As an organization, we actually refer a lot of patients to patientadvocate.org because they help patients deal with insurance issues, which is really valuable. But there weren't really anything for caregivers where we were, even in these big cancer centers. So that was difficult. But there's also this community and online support, and you have the links right there: Liver Onc and MD Junction, liver cancer, and I would only say to liver cancer patients that that is a online support group, but it is not necessarily monitored. So, if another patient mentions something, be sure to ask your doctor about it.
Okay. Karla, at your center, what are the specific support services that particularly people with liver cancer might be able to use?
I think we offer patient sessions, informational type sessions, as well as support group options, both for patients and for family members. I think the other thing that happens, and sometimes patients are in situations, are getting care in places where there aren't all these formal support mechanisms. And I think that as a patient, don't be shy about asking one of your healthcare providers if there's another patient in a similar situation who might be willing to talk to you. Because I have patients ask that, and I have patients who offer to be that, who have been through treatment, who are willing to, obviously with permission on both sides, to say, I would just really love to talk to somebody who is walking in these same shoes. And the power and the support that can come from that can really be amazing sometimes. A lot of times patients end up doing that on their own. They meet people in a waiting room in radiology or wherever and figure out that they're dealing with the same thing. But I think sometimes those informal connections that we can help patients make, obviously with appropriate attention to confidentiality and so forth, can be very powerful and helpful and very real for patients.
Well, one of the issues that we get a lot of questions about are the financial issues. Karla, can you explain what the Employee Assistance Program is? You had mentioned that earlier when we talked.
Absolutely. I think there's certainly a financial impact to cancer treatment, and even if you have a good job and good insurance and stable resources, the cost of back and forth to hospitals and loss, all of that, there's so much that has impact. And all of these little peripheral things of, I need to go for this treatment, who's going to help me get my kids to their after-school activities, things like that. Or I need to do some legal documents and I just don't know where to turn for that. Things like that. A lot of employers have what are called employee assistance programs that are wonderful resources to all manner of community services, be it financial assistance, social work services, counseling for children, support for caregivers, all these things we've been talking about. A lot of larger employees have these employee assistance programs that really have a lot of resources available, and it is a benefit that you have as an employee, and it doesn't cost anything. And I've had patients that have been able to get like legal services, helping to have wills prepared or power of attorney documents, things like that they needed, and getting that referred and covered through an employee assistance program. So I always ask patients, do you have this? Because it's often a benefit that patients have through their work, and they just don't know. They don't realize that it's there.
Yeah. Andrea, you had mentioned something about state assistance programs. Can you give us some more details?
Yes, I encourage people to look into any state and local assistance programs. And, for example, California has the IHSS, which is in-home supportive services, where the caregiver is actually paid to take care of the patient, and also CCS, which is California Children's Services. That's a very specific state program that covers serious, life-threatening, or potentially disabling conditions. And I'm going to jump to the fourth bullet there, but if you have a decent support network, a lot of times family or friends are going to ask, what can I do for you? And if they can't read your mind, I was just talking about this with a cancer survivor, and they can't read your mind. Give them specific tasks. I asked people to do research, and it was actually someone doing research that led to the discovery of the IHSS program, not our social worker at the hospital. And so I was able to get paid to take care of my sister because I did quit my job, and that was very helpful. Another thing we did was, look at the expenses of being in the hospital every day. Where we were, parking was more than $5 a day in the hospital, not to mention meals. And so we had a jar in my sister's room, and we said something, I can't remember exactly what it was, but give a dollar, give a dime, help us pay for parking every time, or something silly like that. But it was amazing because nurses, doctors, the janitor, people would throw change in there all the time. They thought it was a brilliant idea. And so our parking was always paid for, and a lot of our meals were covered because being in the hospital can get very expensive really fast, even when you have good insurance.
Yeah, definitely. And what's the Adrienne Wilson Spirit Award?
The Adrienne Wilson Spirit Award is a patient advocacy award. It is for specifically liver cancer patients who are in some ways advocates for themselves or others during their treatment. It was inspired by a liver cancer patient, Kathy Bryson, during her second battle with liver cancer, which she did lose. And it's a rolling award, and we give out we give money, and the patient can use that toward anything they want. If it's clothes, meals, something on their bucket list. With Kathy Bryson, she used the money we gave her toward to offset some of the cost of her medical care, some things that her insurance was not covering. So, so it was inspired by another patient, and we want to help patients as much as possible.
Yeah, that's great. Karla, I want to go over now to some of the terms that we might be hearing. Palliative care, now that's a term that gets a mixed reaction. It's often confused with other things like hospice care. Can you explain what palliative care is and when it's used?
Mm-hmm. Palliative care is care that focuses on relieving patients' symptoms, pain, addressing physical stress, emotional stress that are associated with a serious illness. And that really is a component of care at every stage of disease for a patient. So a lot of times we hear the word palliative care and we think that that's just supportive care, end-of-life care, but not necessarily. I think the best cancer care that you get has palliative care, attention to managing symptoms and quality of life all throughout, no matter how aggressive or not aggressive a patient might be in terms of chemotherapy or surgery or other options. Palliation should be a part of that care throughout. And that healthcare providers confuse that term, and it's a confusing term to patients. But basically, palliation means managing the symptoms, managing all the things that go along with whatever the underlying problem is, and with the focus being on the patient's quality of life.
Yeah.
You know, and I think it does not mean that a patient isn't or can't pursue aggressive curative treatment at the same time. It's just a component of the care.
Right. And actually the National Cancer Institute has a very useful fact sheet that answers some of these questions about palliative care. So then we get to hospice care. Can you explain what that term means and when is it considered?
Mm-hmm. Hospice care is a type of care, a philosophy of care that is specific to end-of-life care. When a patient who has a terminal illness decides that they're not going to pursue additional aggressive or curative treatments, they may have been receiving palliative care and still getting TACE or chemoembolization, things like that. But hospice care is when you decide that there aren't additional treatment regimens that are going to seek to be curative, and we're moving to a mode where we're going to be purely palliative. We're looking at quality of life and managing symptoms. A lot of times, hospice care comes into play very late in a patient's disease course with HCC, and that may be, as in Adrienne's case, that the patient's in the hospital quite ill, but wishes to be at home. And so hospice care is engaged to provide nursing and other support services so that the patient can move their care from the hospital environment to home. Some patients with liver cancer have a goal that, they're pursuing other treatments and outpatient treatments, but they don't want to be in the hospital, and that one of their goals is to not end up in a hospital. And hospice can play a role in that too, of helping patients manage symptoms so that their pain or their nausea are not symptoms that are being poorly managed that take them to the emergency room late at night and end up with them being hospitalized. So I think it's an important thing to discuss with patients, and I try to talk with patients about it as early as I can, not because I'm not willing to continue to pursue curative or aggressive therapy, but because I want patients to know what options they have, and also to know that those supportive services are out there for them. It helps with some of that uncertainty.
Yeah. Andrea, how do you prepare to shift your family member from the hospital to home? What were the things to consider?
Well, again, everything happened so fast for us that you just kind of have to go with the chaos. So what happened in our case was Adrienne took a very sudden turn for the worse just about 3 to 4 days before she passed away. And we were in the hospital, and she had been in sort of a dreamlike / not a coma state for quite some time, and transferred to critical care at UCLA. And the doctors wanted to put her on a respirator. And we'll talk about this in the next slide, but I knew what my sister wanted intuitively. And that wasn't an option, because I found out if we put on a respirator, we couldn't take her home, and I knew she always wanted to be home. So it was actually my refusal to put her on a respirator is what led to hospice, because her doctor said, well, then she has to go to hospice. And I can't say enough good things about hospice, even though Adrienne was on hospice less than 72 hours, but our hospice nurse came in. It was 5:30 in the morning. At this point, we'd been up for over 24 hours, and it was a big fight not to put her on a respirator. And the hospice nurse came in, and I knew she was supposed to change my mind, because they were really worried about taking her home and her actually dying in the ambulance. And I said to the hospice nurse, I said, it was quite the introduction. I, draped my arms over my sister, and I said, I don't care who you are, this is what needs to be done. We have to go home. She's not going on a respirator. Make it happen. And she was fantastic. She really was. She made it happen. And my sister actually woke up before they ever put her in the ambulance, and was wide awake the whole way home, asking questions about what happened over the last 36 hours she had lost. So.
Yeah, that's great. I'm glad when you can get the outcome that you want in terms of the type of care and where it will be offered. So we come to key takeaways then. Andrea, you said that if you to be an advocate for your health, that's very, very important. What about other things?
I always recommend you seek a second opinion. Always. And we did, and it turned out to be the right thing to do. I highly recommend, and doing this when you're well and not sick, is to prepare an advance directive, also known as a living will, which has nothing to do with things you own. It is strictly about outlining your healthcare wishes and what you want, and you designate a power of attorney that person will enforce your wishes if you're not capable of speaking for yourself, much like I did for my sister and making sure she was not put on a respirator. And more important than what your wishes are really is who your power of attorney is, because sometimes the best possible advocate for you, is not the obvious person. It's not necessarily your spouse or if you're older, your child, because you have to make very, very difficult decisions. And so it's good to have a conversation, I think, about an advance directive with your family while you're healthy.
Okay. Karla, I want to just go over a couple of things before we start with the questions. So I'll come back to your key takeaways at the very end.
Okay.
I'd like to talk, Andrea, a little bit about BlueFaery. Can you give us some information about the organization?
Yes. I started BlueFaery about a year after Adrienne passed away, and it was a way for me to channel my grief and to helping others, because I think liver cancer is one of the worst diseases anyone could ever get, and it shouldn't happen to anybody or their family. And so BlueFaery's mission is to prevent, treat, and cure primary liver cancer, meaning hepatocellular carcinoma, through research, education, and advocacy. So we do have free patient education brochures. They have been distributed all across the nation, over 30 treatment centers, translated into Spanish and Chinese, and one of our medical advisory board doctors actually took our Chinese brochures to China because they didn't have anything like that for patients there where liver cancer is rampant. We have a research award that we give out on my sister's birthday for doctors who are specifically doing research and studies in HCC. And as we mentioned earlier, we have the Adrienne Wilson Spirit Award, which is for patients who advocate for themselves and or others during their treatment.
Thank you. I'll give a little bit of a description of Liver Cancer Connect, the dedicated program of the Hepatitis B Foundation. We have a Liver Cancer Center directory, and as I mentioned earlier, and a drug watch, which lists drugs in development, many of which are in clinical trials. And also, we provide information on how to understand your diagnosis, talking to your healthcare team, and treatment options. I want to also mention another resource for families. That's Hep B United, which is a national coalition founded by the Hepatitis B Foundation and APCHO, which is the Association of Asian Pacific Community Health Organizations. Hep B United serves all communities, and in particular the Asian and Pacific Islander communities, which are disproportionately affected by hepatitis B and liver cancer. And the Hep B United coalition partners are across the country, and they can help families gain access to translation services, information about health insurance and drug reimbursement, and connect to a physician who can speak their language. In addition, Hep B United's clinic partners, which are in several cities across the country, also do liver cancer screenings for their patients who have hepatitis B, and they provide referrals for liver cancer services. Here's another list of some of the resources. Again, this is not a comprehensive list, but it's just something that you can use to get started when you're looking for support services. And I'd like to now go back to Karla. If you could give us some of your key takeaways that you can give to families and patients facing liver cancer.
I think a couple of things. I think the world of healthcare with a diagnosis such as hepatocellular carcinoma can be really confusing and an absolute blur. You've got multiple doctors, multiple different providers. You're going to a million different appointments, different imaging, all kinds of tests. It can be really, really confusing. And we as healthcare providers tend to speak in a language that isn't always understandable to our patients. And so I think one of my key takeaways would be, don't be shy about asking questions and saying, I don't know what that means. Explain that to me. Don't be shy about asking what you think might be a not-so-smart question or a silly question or an obvious question. There are no stupid questions when it's finding out information about your health. So don't be shy about that. Ask for things in writing. I think Andrea and I both have touched on that through this, and I think that that's really important. I think, with our use of electronic medical records now, we have the ability to do very detailed written instructions, and if your providers aren't providing you that, ask for it, because that can really help in terms of, as you go from doctor to doctor, taking information back and forth, and just for you to know what, sometimes you have a visit and you get home and you think, I know she said something about that, but I don't remember. And I think then the other thing, referencing Andrea's spiral notebook, is to have either write things down yourself or have someone who, if you will, functions as your secretary, someone who's your eyes and ears at an appointment, so that you can go and listen and ask questions, and they can be there to listen and help you remember and understand those things. Because sometimes there's so much information, it's really hard to remember it once you get home, or to sort of remember exactly what it meant. And so having another set of eyes and ears can really be a helpful thing.
Yeah. Well, I think that comes to the end of our presentation. Before we have one or two questions, I want to thank you both, Karla and Andrea, for a very informative webinar, and all the participants who joined us. One question that we've received is, we heard that liver cancer, one of the risk factors is a family history of liver cancer. So is testing for family members necessary, and why is this done?
It can be a very important thing, and it really depends. Some liver cancers, I think that is a question that we ask patients. Do you have a family history of liver cancer? And if a patient says, yes, my dad had liver cancer, we're going to ask more questions about, well, what do you know what kind of liver disease he had? Some of the autoimmune liver diseases can sort of run in families. And so patients can be at risk. Certainly the viral hepatitis, such as with Adrienne, who was possibly infected at birth or perinatally, those, do your parents have hepatitis A or B? Have they been screened for hepatitis A or B, B or C? And do you have children, and have they been tested? Have they been vaccinated? Those are really, really important questions, especially with regard to hepatitis B, which is endemic in so many populations. And, we have patients, we're here in the Washington, D.C. area, and it's a very transient international population, and we have patients in their 40s and 50s who are sort of coming to us for the first time, being diagnosed with hepatitis B, who have children and who have parents, and people out there who haven't been tested. It's so important, because patients, you don't get screened for liver cancer unless you have a risk for liver cancer. And so if you don't know that you have an underlying liver disease, you won't be getting the care you need, including the surveillance to prevent liver cancer or to detect liver cancer.
Right. Well, thank you. I think that comes to the end of our time, and I don't see any other questions on the screen. So thank you again, Karla and Andrea, and thank you to everyone who joined us today. We hope you heard some valuable information, and we wish you all the very best as you face the daunting challenge of liver cancer. Just as a reminder, we will be posting this webinar along with our other liver cancer webinars on livercancerconnect.org and hepb.org. Thank you again very much for joining us today. This concludes our webinar.